Hi, everyone. This is Liz Woodruff. I'm the director of the IAFP. Happy to welcome you here for our November grand rounds on death certificates with Dr. Demsie Butler from the Magic Valley Full Circle Health Program. I have dropped information in the chat to receive CME for today's event. You can either email me or click on the link. I'll be dropping that in throughout today's presentation. You will receive your CME certificate within the next month. Dr. Butler will give her presentation for about 45 minutes. It sounds like it's interactive, but you're welcome to put questions into the chat throughout the presentation that may be answered at the end, or at the end, you'll have a chance to unmute yourself and ask your questions directly. Just a quick reminder that our December grand rounds is at a slightly different time. It's going to be noon Pacific time and 1 p.m. Mountain time, so that we can accommodate a presentation from the Kootenai Health Program, which is on Pacific time. Thank you so much for being here today. We are recording this and it will live in our CME library. It will not be available for CME credit there, but you can view it there within the next month or so. Dr. Butler, please take it away.
Awesome. Thank you so much. My name is Dr. Butler. I'm a third-year resident at Magic Valley Full Circle Health in Jerome and Twin Falls. I thought I would do my topic for grand rounds on death certificates because I feel like we don't actually receive that much training in residency. And as soon as we graduate, we're expected to just know how to fill these for primary care. So I think that it's very important for us to have some sort of training in how to fill them out properly. I just want to give you a little caveat that I'm just a resident, and so a lot of my information that I obtained and examples that I obtained are from others that I have received resources from, including the Physician's Handbook on death certificates, as well as I had a contact with the King County Medical Examiner's Office, and I used some of their examples. So again, with me being a resident, I have no conflicts of interest. No one has given me any free food, so no conflicts of interest here for me. I feel like just some overall objectives for this talk is going to be the importance of death certificates, who's actually responsible for filling out a certificate, the differences between state legislatives' roles and manner of death, as well as cause of death. We will also be doing examples, and I'll be looking at the chat, or you feel free to unmute yourself and let me know what you think some of the manners of death or causes of death for the examples that I have coming up. So why is this important? It is important because a death certificate is a fact of death. People cannot actually bury someone or cremate someone or even transport a body without a deposition permit. So none of this can be completed until after the death certificate is completed. This causes a lot of contention because there is a certain time frame, especially in certain states, where a death certificate needs to be completed for families, in order for families to be able to process and grieve their loved one. It's also really important because a lot of our statistics come from death certificates. So the CDC Wonder, the National Center for Health Statistics, does use your coding on a death certificate to see what the most common diseases are causing mortality, whether smoking was involved. This also can lead public health goals as well as research funding. So it's very important that we complete a death certificate as well as accurate to the best of our ability. So what is our exact role? It's really important to know that this is our final act of patient care. In family medicine, we're all about all stages of life. I think we talk from birth to death. And I think a lot of times we always love to talk about the birth because newborns and everything's great. But when it becomes to someone's death, which can be a little bit more gruesome and a lot more contention with family, that it can be sometimes difficult for providers to complete death certificates. And I think I want you to remember that not only are you doing this for the patient, but you're doing this for their family, for them to be able to grieve in the right amount of time frame. And I want you to also know that even though you are certified at the Board of Medicine, that does not mean that you can actually fill out a death certificate. You have to go through either the electronic death certificate registration system or register with the state to be able to certify death certificates. So you have to do two different things. You also need to be familiar with local regulation to see if you are working with a coroner-based system or a medical examiner-based system. And then you also need to understand that this is a confidential encounter, just like all of your interactions with your patient before this last stage of their life. So there's actually a standardized death certificate, and each state can either rule in certain things on the death certificate or change it in some way. A lot of the times, the registration of death, who changes this, can also be the American Medical Association, the National Association of Medical Examiners, the College of American Pathologists, and the American Hospital Association. They frequently get together if there's any changes that need to be done to the standardized death certificate. And I will say the majority of states are electronic. However, if you have your old codger family medicine doctor who refuses to use electronic systems, there are paper death certificates out there that some still use to this day. This is the example of a standardized death certificate. There is what the funeral home is in charge of. And the middle portion, which is highlighted in blue, is what we will be in charge of. It is considered the medical portion of the certificate. So each state is actually pretty unique. In Idaho, we are a county-based state and also a coroner-based state. So we don't actually have a medical examiner in the state of Idaho. We have forensic pathologists that can perform autopsies if needed. For instance, Ada County has, I think, about 2 forensic pathologists that are trained to perform autopsies. So it's available to Idaho if needed. Sometimes there can be traveling medical examiners. If there's concern for an autopsy, they can travel to that area to perform the autopsy. But let's say, for instance, in Twin Falls County, the coroner is concerned and needs an autopsy. A lot of the times he will send them over to Ada County to perform the autopsy. Or if the patient passes away in the hospital, each hospital should have a pathologist that's trained in autopsies. For instance, Magic Valley Hospital here in Twin Falls has one, whereas if they were unconcerned or unsure, they could always send the body to the Boise St. Luke's system. But it should be obtained by the hospital pathologists. I think it's kind of unique in Washington. There is a population-based system. So if you're below a certain population, it's actually just a county official who is in charge of death certification. If they have a little bit more in their population, it would be a coroner. But if they have over 249,000 people in their population, they are required by state law to have a medical examiner in that county. For instance, King County in Seattle has a medical examiner. And then I think Utah is a little bit different because it's actually a district and there's only one medical examiner. And it's important to kind of know what type of medical examiner there is, because there are certain states where the medical examiner is not actually trained physician. They were more likely appointed the position and they can perform autopsies, but they have no medical background. Coroners are elected. And then this link is really nice. So if you end up working in Idaho or you end up going somewhere different, you can always click this link and it will actually tell you by which state you're at, what type of system that they have for their death investigation. So everyone likes to talk about jurisdiction. So who's responsible for actually filling out this death certificate? It's actually kind of contentious. A lot of people are like, no, it's supposed to be the physician who fills it out. No, it has to be the coroner or the medical examiner. I think a good rule of thumb, according to the handbook, is that if it's a natural death, it's going to be the physician who fills out. Oh, I don't know how to mute. Okay. It's just going to be the physician who fills out the natural. Awesome. It's going to be the physician who has to fill out the natural death certificate. If there is any uncertainty whatsoever, or it was an accident, a homicide, suicide, or undetermined, it's going to be the medical examiner or coroner in that system. I put in a little snippet from Idaho Code. So our Idaho Code says medical data shall be supplied by the physician, physician assistant, or advanced registered nurse who attended the deceased during the last illness. So this is very, very broad. So this means that if you filled out an automatic refill for metformin or insulin for someone and they passed away from natural causes, the coroner can be asking you to fill out the death certificate. Some people don't really like that, but that is something that can happen. Or for instance, if you're with a large group of individuals or providers, within that group, if your provider, they went on vacation, you might get in your inbox, hey, can you fill out this death certificate for so-and-so because they're out on vacation? So you would be in charge of filling out the death certificate then. What's even more interesting is if someone passes away in the hospital. So let's say that you're working at the Twin Falls Hospital and you're the attending physician during the day, you would be in charge of filling out the death certificate. If they did not see any physician in their lifetime whatsoever, it'd be in charge of the medical examiner or the coroner to fill out the death certificate. Okay. And then the link on the bottom is actually the code for the full Idaho code for death certificates. I know that Zoom can be a little bit difficult sometimes, so I'm not going to actually click on this link. And I think that because jurisdiction falls under the manner of death, I think we should go over a couple of examples that are kind of unique that might be confusing to see if we can decipher whether it's natural, homicidal, accidental, or undetermined. So I'm going to go ahead and read this case. It is a 72-year-old male with degenerative calcific aortic stenosis who underwent valve replacement after successful treatment of a bout of congestive heart failure. The operative procedure was uneventful until its conclusion when the patient could not be weaned from the pump, and he was pronounced dead in the OR. Would you say his manner of death was natural, homicide, accident, suicide, or undetermined? Again, you can just type in the chat or you can unmute yourself. Awesome. So Christopher Partridge, you said natural, which is correct. A lot of people think that if you died in the OR, it has to be accidental or something happened to them. But because they died of natural causes where they had congestive heart failure, it's actually a natural death. So it'd be the hospital team that would be in charge of performing the death certificate. This is kind of an interesting point, but so let's say, for instance, someone had a hip fracture. If they had a hip fracture because of just older age, the process of osteoporosis, or a bone cancer, more like a degenerative change, that would be a natural process. But let's say that the individual fell, causing the hip fracture. That would be considered an accident. So you wouldn't actually fill out the death certificate. It would be the coroner or the medical examiner. How about this case here? This is a 45-year-old male who was witnessed to have confronted by an armed robber and threatened with a gun. As the victim reached for his wallet, he collapsed and was dead when approached moments later. Autopsies revealed multifocal atherosclerosis and 75% stenosis, and the tox was negative. How did he die? What was the manner of death?
Not natural.
We have not natural. So is it homicide, suicide, accident? We say, Dr. Irwin says natural. This is actually kind of controversial. So this individual actually died by homicide. We call it homicide by heart attack because he would not have had the heart attack if he was not attacked by the armed robber. So you would not be in charge of filling out this death certificate. This is a 38-year-old male with chronic indwelling urinary catheter who develops a UTI and dies. The catheter was placed due to paraplegia resulting from a shrapnel-induced spinal cord injury sustained 14 years previously in military combat. Did he die naturally? Did he die by accident, homicide, or undetermined? Dr. Kern says natural. Dr. Browning says natural. This is what I had initially thought, that it was a natural death, but ultimately he died because he had that spinal cord injury from combat. So he actually died by homicide because he would not have had the catheter if he had not been in military combat and had received that injury. So you would not be in charge of performing this death certificate. I bring these special cases up because some deaths may seem natural, but if they have anything that could complicate the injury or poisoning that contributed to their death, you need to make sure and pause and be like, maybe I'm not actually responsible for this death certificate. It's actually going to be the coroner or medical examiner, and an autopsy may need to be obtained. These are examples of certain things that may require further evaluation that may seem natural but are not. This brings me to the medical certification of the death certificate. This has lots of things that you have to fill out. A lot of the times it's electronic. If there's an electronic option, I encourage you to choose that instead of trying to write down a death certificate. And this can differ from state to state, but typically, let's say if you're in the hospital and you're the attending physician during the day and you have a pretty sick patient, but overnight they code and they die. The night doctor would be in charge of pronouncing the patient dead. So they would be in charge of 24 through 31. But the actual day team doctor, the one that's seen them the most, who's in charge of them, would be responsible for certifying the death and filling out the rest of the death certificate. It's a little bit different in Idaho. There's actually no pronouncer and certifier. That is just together. So you would actually just be filling out both portions of the death certificate. That's the one caveat that's different for Idaho. And I know that I was very much like, you must complete everything. This is very important. There is a little bit of a trick. So if there's an autopsy findings section and it asks if an autopsy was performed, if there was no autopsy performed, you need to leave it blank. By saying no or yes on it, you are saying that there's autopsy findings that are pending that have not been resulted yet. So that's a little bit of a trick when it comes to this death certificate. So if you had a natural death at home, you're not going to perform an autopsy, you leave that portion blank. The only thing that I want you to leave blank. So here's some tips and tricks for filling out the death certificate. You have to complete each item assigned to you. It's very important that you don't mess this up because they can't be cremated, they can't be buried, they can't be with their family, and it's very important. If you are writing it out, please be legible, no cursive whatsoever. No abbreviations. I know as doctors we love abbreviations, but we cannot use abbreviations in the death certificate. And please check your spelling. Also, no ICD-10 codes. I don't know, I can't believe I have to say this here, but no ICD-10 codes. I've looked at lots of examples of death certificates that are incorrect, and please don't do that. Also, you cannot use any brand names. You can use generic names, but not brand names. You can, and being generic would be still specific and precise. For instance, let's say for some reason that the medical examiner or coroner does not accept jurisdiction on a patient who died of an injury at the Chobani yogurt factory. You could not put in the injury section that it was at Chobani factory. You'd have to say like yogurt factory or manufacturing factory, specific without using names. Or if they had died along the highway, you'd want the highway number. And precise would be, don't just put dementia. What type of dementia was it? What type of diabetes? Where was their stroke? That kind of information. Also, you make sure that you sign the death certificate. Months have to be in full name. So like January, February, March, you can't use 1/2, things like that. It's also a 24-hour clock for time frames, with midnight being 0000. You are allowed to use approximately if you're not entirely sure, because this is your best medical opinion when filling out death certificates. You can use the words presumed or probable or possible. If you're using the word unknown, you probably should not be filling out that death certificate. It's not actually your responsibility for unknown. That has to be, an autopsy might have to be performed. So it would be either the coroner or the medical examiner filling out that death certificate. And most importantly, this is time sensitive. In the state of Idaho, for I don't want to like threaten people, but for the state of Idaho, there are repercussions if you don't get it done on time. So you have 72 hours from pronouncing death to certifying the death. If you're going longer than that, it could be fined $250 per day. The state does not have the ability to suspend a license, but there have been times where the Board of Medicine has had to take action against a doctor not signing a death certificate. Also, if you're not filling them out in a timely manner, complaints can be filed to the Idaho Board of Medicine. And I don't want you guys to feel threatened by this slide, but I hope that you remember that there are people who are waiting to take care of their loved ones, that there's funeral processing that needs to be done. Even in some religions, they have 24 hours to bury their loved ones. So I hope that you would take that into consideration when filling out your death certificates. So I think the most confusing part about death certificates is cause of death. So I was going to do quite a few examples with you guys if you'll hopefully be very interactive. But cause of death, there are two parts to the cause of death portion of the death certificate. There is the reporting the sequences and events leading to the death and things that have contributed to the death. And I think that's important to reiterate and go through some examples because it can be kind of confusing. Because it's so confusing, I thought that I would kind of bring up an example that we can kind of use throughout these instances. I don't know if you guys grew up listening to There Was an Old Lady Who Swallowed a Fly, Perhaps She'll Die, but I think it's a good way to think about when you're trying to figure out a death certificate. For instance, the old lady, she swallowed a fly, but that didn't kill her, but she tried to eat a spider and various animals until when she ate the horse, and she died, of course. I don't know if you remember that nursery rhyme. So the horse was the immediate cause of her death, but she wouldn't have eaten the horse if she didn't ultimately eat the fly. So the fly is actually the underlying cause of her death. So you have your immediate cause and your underlying cause. These next two slides are just examples of instances that you cannot actually use as the underlying cause of death. So these cannot be the fly, the ultimate thing that killed an individual. And I think it's important to just note that there are quite a few things that maybe people have in the past written as the ultimate underlying cause. Because there's quite a few of them out there. Okay, so this is actually what the cause of death certificate portion looks like. We have your part 1 and your part 2. And then on this side over here, we have the interval time where it can be approximate or a date range in the state of Idaho. Or even when I was in King County Medical Examiners, you can use things like, hours, months, days, years. But this has to be filled out. Everything in this section has to be filled out. Everyone ready for some cases? I sure this is clear as mud. So this is case 1. This is, so shortly after dinner on the day before admission to the hospital, a 48-year-old male developed a cramping epigastric pain. It radiated to his back. He had nausea and vomiting. The pain was not relieved by positional changes. The pain persisted, and 24 hours after, he sought medical attention. He has a 10-year history of excessive alcohol consumption and a 2-year history of frequent episodes of epigastric pain. The patient denied diarrhea, constipation, blood in the vomit, and the stool. He was admitted and found to have acute on chronic pancreatitis. Imaging found a duodenal ileus and pancreatic calcification. His serum amylase was 4,000. The day after admission, he seemed to improve. However, he became disoriented, restless, and hypotensive. Despite IV fluids and vasopressors, the patient remained hypotensive and died. Autopsy findings revealed many areas of fibrosis in the pancreas, with the remaining areas showing multifoci of acute inflammation and necrosis. So thinking about the little old lady, so the horse, the immediate cause of his death. Anyone have any thoughts on what would be the immediate cause of this individual's death? This is one of the harder ones. A lot of people think it was shock that killed him. So the immediate cause of his death, the reason he went into shock is more like a verb. So shock and arrest are things that cannot be used on the death certificate. Those are more like mechanisms of action. So he had this duodenal ileus. And so the duodenal ileus was the immediate cause of his death. And he ultimately got that because he had chronic pancreatitis. And he had the chronic pancreatitis because he had alcohol consumption. So the duodenal ileus was within days, the chronic pancreatitis was within years, and the alcoholism was within 10 years. So duodenal ileus and pancreatic calcification, they are non-specific processes because you're not sure, what caused that? Was that an infection? Was that a mass, such as a cancer that caused it? Or was it because of pancreatitis in this instance? So you cannot actually use that as the underlying cause. It can be an immediate cause, though. So in this second case, we have this one. I think you guys can get this one. It's kind of got a nice sequence of events. This is a 68-year-old male who was admitted to the hospital with progressive right lower quadrant pain of several weeks duration. He lost approximately 40 pounds and had experienced progressive weakness and malaise. On physical exam, he had an enlarged liver span that was 4 finger breadths below the right costal margin. Rectal exam was normal and stool was negative for occult blood. Lab tests were within normal limits. A chest x-ray and barium enema were negative. His EKG showed a right bundle branch block. CT scan showed numerous masses within both lobes of the liver. A biopsy showed carcinoma, and he was started on chemotherapy. 3 months later, he developed decrease in liver function and a DVT in his left thigh. He was admitted to the hospital, developed a PE, and passed away. So with what would we think is the immediate cause for this individual to have passed away?
I saw PE was on the list of ones you can't use, so it's got to be something else.
So you can't use it as the underlying cause, but it can be used as an immediate cause. So the immediate cause for his death is correct, the pulmonary embolism.
Oh, I see.
But something has to have caused that. So you can't just keep PE and keep it like that. So the PE was caused from what do we look for when we get a PE? Where did he get his PE from?
Hypercoagulability from the carcinoma.
Yeah, so in the cancer. So he got the pulmonary embolism. That was because he had a DVT from his left thigh. That was because he had hepatic failure, and the hepatic failure was because he had moderately differentiated hepatocellular carcinoma. So the underlying cause, the actual fly that killed him, was the cancer, but these are the sequence of events that led to his death. And of course, we have, if you paid, like in the case, it gives us specific numbers, so we're able to put 30 minutes, 3 days, over 3 months in this death certificate. We're being a little bit of a Sherlock Holmes right now. In this case, we have a 75-year-old male who was admitted to the hospital complaining of severe chest pain. He had a 10-year history of atherosclerotic heart disease with a MI and several episodes of congestive heart failure controlled by digitalis and diuretics. 5 months before the admission, he was found to be anemic with a hematocrit of 17. He had blood in his stool, and a barium enema showed a carcinoma by biopsy. Because of his cardiac status, he decided not to do surgery. He was treated with 5 weeks of radiation and red blood cell transfusions. He completed this course over 3 months before he was admitted to the hospital, found to have an acute anterior wall myocardial infarction, and he died 2 days later. So for this individual, what was his immediate cause? What ultimate, like, was the horse, of course, that killed this individual? Yeah, Dr. Browning, nice job. It was the MI. So what caused the MI? Why did he have a heart attack?
Arteriosclerotic heart disease.
Yeah. So a lot of people will think, well, it was the cancer. So I think this is a good example of the fact that the patient died of an acute myocardial infarction because of the atherosclerotic heart disease. And contributing was the cancer, the carcinoma of the cecum, and the congestive heart failure. The reason why congestive heart failure is listed in part 2 is because it weakened the patient, but was not in the actual causal sequence of an MI. Because an MI is, the decrease in vessels and blood flow to the heart, which is more atherosclerotic heart disease and not actually heart failure, which is a different mechanism. You guys are doing good. We only have a few more left. A 78-year-old female with a temperature of 102.6 was admitted to the hospital from a nursing home. She first became a resident of the nursing home 2 years earlier, following a CVA that left her with a residual left hemiparesis. Over the next year, she became increasingly dependent on others to help her with activities of daily living. She eventually required an indwelling bladder catheter 6 months before her current admission. 3 days before admission, she was having poor appetite and increasingly withdrawn. On admission to the hospital, she had an elevated white blood cell count in her urine. She had gram-negative rods that were seen on her urine. She was started on antibiotic therapy, and on the third hospital stay, blood cultures revealed Pseudomonas aeruginosa, and which was resistant to antibiotic therapy. So they switched antibiotic therapy, and despite that, she persisted to do unwell and perished. So for this individual, what was the immediate cause of this person's death?
Septic shock.
Yeah. We can be a little bit more specific in this case and actually use the organism because we know it. So it's Pseudomonas sepsis. Because remember, shock and arrest, those are verbs. So you can't actually put them, they're a mechanism of action. So you can't actually put it in the immediate cause. So you can say Pseudomonas sepsis, and they got Pseudomonas sepsis from what? Due to what? We found pyuria. Yep, pyelonephritis. So Pseudomonas aeruginosa urinary tract infection. And the reason why they probably had a UTI was because they had an indwelling catheter. And they had an indwelling catheter because of the left hemiparesis that was due to an old cerebral vascular accident. I think this is a good example of a death certificate where when you have multiple causal sequences, on the last line of the death certificate, you are allowed to use due to. You can say left hemiparesis due to old cerebral vascular accident. You can have multiple conditions on the same line if you have a lot of sequences of events. It's equivalent to adding an additional line to your death certificate. So this was a 34-year-old male who was admitted to the hospital with severe shortness of breath. He had a 9-month history of unintentional weight loss, night sweats, and diarrhea. The patient had no history of any medical condition that would cause immunodeficiency. They did some testing and confirmed he was positive for HIV. He did have low T helper ratio, and a lung biopsy showed pneumocystis pneumonia, indicating a diagnosis of AIDS. He was admitted multiple times for the pneumonia with therapy, and then 17 months after he was first diagnosed, he developed PCP again, but he did not respond to therapy this time, and he died 2 weeks later. So what do you believe is the immediate cause for this person perishing? Ah, nice, Dr. Woldred's PCP. What caused the PCP pneumonia? That was redundant. Awesome. And what caused the autoimmune deficiency syndrome? Nice. So you guys are all correct, but I want to remember when you're filling out the death certificate, you cannot use abbreviations. And I think this is a good example where we're always using abbreviations. You have to say the full terminology out loud, but you did have it correct. Some people believe that HIV and AIDS are synonymous, but they're actually not. It's a variable clinical course, and you can have HIV infection, but not AIDS. And so I think that it's important to make note of that, especially if you're filling out a death certificate. And no abbreviations. That's awesome. And then in case history number 8, we have a 75-year-old male who had a 10-year history of chronic bronchitis associated with smoking 2 packs of cigarettes per day for more than 40 years. When seen by his physician approximately 2 years before his terminal episode, he had moderately reduced lung function with no response to bronchodilators. During his last year, he required steroids to prevent wheezing and coughing at night. However, he was unable to reduce his smoking to less than 1 pack of cigarettes per day. When seen 3 months before his terminal episode, he had significantly reduced lung function with no response to bronchodilators. He awoke one evening complaining to his wife about coughing and worsening shortness of breath. He was taken to the emergency room where he was found to have an acute exacerbation of obstructive airway disease. He was admitted to the hospital. At the patient's request, no mechanical ventilation was employed, and he died 12 hours later in respiratory arrest. What was the immediate cause of this individual's death? Hypoxemic respiratory failure. I think that that's a really good point to bring out, that respiratory failure and respiratory arrest, these are actual mechanisms of action. And again, they're not actually listed as the immediate causes of death. So this person had an acute exacerbation of obstructive airway disease that was due to chronic bronchitis. And contributing would be the cigarette smoking. It's kind of hard to wrap our brains around this, the fact that respiratory arrest, septic shock, and failure, they are a verb. You can't put them in a box, so you should not put them in a box in the cause of death. This is a really good one where an individual who's a 53-year-old male was admitted to the hospital after 2 days of intermittent mild epigastric left-sided chest pain. The pain radiated to his left arm and was accompanied by nausea and vomiting. He had a 2-year history of occasional chest discomfort, syncope for 6 months, hypertension, smoking, congenital blindness, and insulin-dependent diabetes mellitus. He was noted to be markedly obese and to have severe hypercholesterolemia. At the time of his admission, his enzyme studies were normal, but EKG suggested an MI. 2 days later, he experienced an episode of severe chest pain that did not respond to nitroglycerin and was accompanied by ST segment elevation. A cardiac cath demonstrated severe multivessel coronary artery stenosis. He underwent quadruple bypass surgery. Shortly after being taken off the bypass machine, he went into cardiac arrest. A resuscitation by open cardiac massage was attempted. However, he had a ruptured left ventricle that caused rapid exsanguination and death. So this is a case where someone had passed away in the operating room. What would be the immediate cause for this person's death? Correct, Dr. Browning. It was the rupture of the left ventricle, and the reason why what's a complication that can cause a left ventricle rupture? What do you think caused it?
Would you put CPR there?
So remember that a complication of a myocardial infarction is a rupture of a ventricle.
Okay.
So he had a rupture of his left ventricle due to his myocardial infarction that was due to the coronary atherosclerosis. Contributing factors, a lot of people will think surgery needs to go in the part 1, but it's actually a contributor, so it goes in part 2. And other contributors to his death is the insulin-dependent diabetes mellitus, the cigarette smoking, hypertension, and hypercholesterolemia. So I'm sure I've kind of confused a lot of people right now, but hopefully if you have any questions, you are able to actually use the physician's handbook on death certificates, which is a great resource. CDC also has an app called the Cause of Death mobile application. I think that this is a nice quick reference guide if you're not entirely sure how to fill out someone's death certificate. You can also phone a friend if you ever have issues. I really want to thank Dan Irwin, who's at the Idaho Department of Health and Welfare, who helped me with resources for this talk, as well as discussing with our county coroner in Twin Falls, Will Carson, as well as discussing cases with Dr. Lubin, who is a King County Medical Examiner's Office. There were great resources that helped me put this talk together. I have more slides, but I think that we'll stop for now. Also, all of my examples are from the physician's handbook on medical certification of death, if you wanted to go into these death certificates in more detail.
Thank you so much, Dr. Butler. It sounds like death certificates are kind of hard, so I'm glad that everybody had a chance to hear your presentation. Does anybody have any direct questions for Dr. Butler? You're welcome to unmute or put those in the chat. And I have just dropped my email address and the Google form to get CME for today's event into the chat again. I apologize. I don't know if anybody noticed, but my computer crashed in the middle of the presentation and I made it back in. I hope that didn't create any disruptions for anybody else. It seemed like everything was fine when I arrived again. Thank you all for being here today. We will have a recording of this on the IAFP's website in our CME library. For those of you that have filled out the form to receive CME, you'll get those certificates in the next month or so. And again, just a reminder that our next grand rounds in December is taking place on Monday, December 9th, but it is a little later. It will be at 1 p.m. Mountain Time, 12 p.m. Pacific Time. Dr. Butler, was there anything else you wanted to add or share before we end?
No, that was it. If you have questions, you can always email me and I can help best of my ability.
Great. Thank you so much for today's presentation, and we hope to see you all again in December.